Hello, and welcome to this panel on universal health. My name is Tanya Lewis, and I'm a senior health and medicine editor for Scientific American, and I will be the moderator today. So I'll just give a brief introduction to the topic and then introduce our panel. Sorry, I'm getting a bit of an echo. I'm not sure if it's on my end. Anyway, so basically, as I said, the topic is universal health, and this is one of the UN's Sustainable Development Goals, yet so much of the world still lacks access to this basic human right. The pandemic has shown us just how important public health is and just how far we have to go, but it has also given us an opportunity to see places where we need to improve and some of the best practices for extending access to healthcare to a much broader population. So I'd like to go ahead and introduce our panel. We have Professor Miriam Ware from the Champions for an AIDS-Free Generation, and Dr. Matshidiso Moeti of the World Health Organization. She's the Regional Director for Africa. Dr. Carl Manlin, VP of Social Impact at Visa, and the former Chief Operating Officer at the EcoBank Foundation, and a 2016 New Voices Fellow at the Aspen Institute Industry. And of course, we have President Julio Frank of the University of Miami as well. So welcome everyone. I'm really looking forward to a lively discussion. And for our audience, if you have questions, you can just ask them. There's a little box at the bottom of your screen that says ask a question. So please go ahead and put your questions in there. And we will try to get to those at the end of the discussion. So I just wanted to start off with a sort of broad question, which is kind of asking everyone where you see progress toward universal health today and where you think the biggest areas of improvement are. So I can start with you, Professor Ware, or sorry, Dr. Ware. I apologize. Do you want to kick us off and talk about sort of where you think that the biggest areas for improvement are?
I think I must say that I'm a bit worried about getting to universal health coverage because I don't feel that we are as close as we should have been by now. Now, for instance, in the 2000 report by the WHO says that even by 2030, we shall have over 700 million who have not yet access to good health care, which means now we have over 1 billion people, 1.5, some estimates say 1.3. So we are not doing as well as I wish we were doing. And some of these people are in desperate situations. I think the regional director for Africa can give us a more precise statement on the African situation. But being in Africa myself, I think that we are not doing as well as we might have been doing. So there have been some improvements, but the COVID has also arrested our movements, and it is threatening to affect us even more. The areas which have done very well in controlling COVID, like the West Pacific, are the same areas which seem on track to get to universal health coverage even before 2030. So I think that we need to have really special approaches to get the rest of the world in Asia and in Africa through universal health coverage. I think there will be need for special interventions. I don't think it will just be life as usual, services as usual, and get us there. I think we shall need special interventions, which I might mention a bit later on. So those are my opening remarks, that I'm worried that we may not get there.
Yeah, me too. um, Dr. Mueti, do you want to talk a little bit about, what you think are, some of the places that are doing well, and specifically some of the models that we can look to, for example, with community-based health, and what lessons we can learn about how to bring healthcare um, to people themselves instead of the other way around.
Yeah. Okay. Thanks very much, and thanks for having invited me to this panel. I mean, I think just starting off, I'd like to say that as WHO, we monitor global progress towards universal health coverage. So there's an index that we are using in the region, which is an index that's been developed at the global level to measure service coverage, for example, which looks at several aspects. First, it looks at several population subgroups and groups of diseases, so reproductive, maternal, and child care, infectious diseases, non-communicable diseases, which are thought to be not important in Africa, which are really coming up in importance. Excuse me. And then it also looks at capacity to provide services, meaning human resources, staff, which is very important in line with what Miriam has just said. And then other proxy indicators for service, for infrastructure, so bed capacity per population, and most importantly, in relation to the fact that we're in the middle of a pandemic, the capacities for international health regulations. I mean, we do think that this index can, with experience, be improved, but it's what we have for the moment been using at the global level to monitor this. And then the other indicator, which is very important, is a key issue, is around spending on health and the percentage of households experiencing what we call catastrophic health spending. Maybe people who don't have health insurance, which is an important political policy decision that countries make and governments put into practice. So where are we going? I think if we look at this index overall, we see that African countries are headed in the right direction. But I agree very much with Miriam that the pace needs to speed up considerably. So looking between 2015 and 2017, using this service coverage index, in Africa, there was an improvement from 45 to 47 out of 100 points, while we noticed that overall the global score remained static at 66. So Africa is lower than the global average, has made some movement. And we saw that this improvement was largely in low and lower middle income countries. In terms of financing, so some of the areas to look at, we noticed that just over 7% of households face really catastrophic health expenditures, meaning more than 10% of the income in the household is spent on health. And on the surface, this looks better than Europe, which is at 7.4%, or the global average of 12.7%. But with a huge range, in countries like Sierra Leone, 54% of households are facing catastrophic health expenditures. And in quite a few countries, Uganda, Nigeria, it's about 15%. So financing is clearly something that needs to be worked on and improved in countries. And I've seen African countries try to develop policies to provide health insurance, including to the lowest income households, try to make some adaptations there, and realize that this needs a lot more effort, including additional investment of public finances. And as we have seen that some of the countries that are performing the best with the best financial protection are also performing best as far as health is concerned. So countries like the Zambias, Botswana, Ghana, and Namibias, these have largely public funded services, and the countries like the Gambia as well. So if we look at why it is that this is the situation, we might think Africans are spending less on health, but sometimes the barriers, the competition for their resources, including sometimes transport costs to reach a health facility, are huge barriers. And then also the quality of the healthcare that people are receiving is a problem. So what are some of the things that need to be happening? We've noticed that the countries that are doing better are those that have explicitly adopted approaches that address equity, that try to address the most vulnerable population subgroups, the lowest income households, and a primary care approach. So try to have infrastructure, healthcare workers with the right competencies closest to where people are, and have a range of human resources, including very much those countries that have invested in community health workers. So at the, at the lowest or closest to the household level of the primary of the healthcare system. So a country like Ethiopia, for example, which now for some time has invested within the public sector in community healthcare workers that are regularly paid, that are available in a sustainable and predictable fashion, unlike some of the initiatives that we have where this is happening at more of a voluntary fashion, have shown impact in terms of outcomes in health. So I believe we need a combination of strategies. Certainly, there's need for additional financing for health, additional investments. Countries need to improve this. They need to look at equity and look at reducing out-of-pocket expenditures for families, especially those lowest in income. You know, we have some countries in Africa where there is a big investment in hospitals in the capital cities, where you then get a concentration of the human resources for health. In some countries, there's a huge difference between the proportion of doctors in the country that are in capital cities, urban areas, and those that are in rural areas. So the distribution of healthcare workers, their competence, their motivation, retention, these are all issues to do with policy, and then ensuring that the infrastructure is built as well in the countries and helping families, households not to have to spend catastrophically on health through carrying out, developing the right kind of policies, packages, social health insurance, and supporting and investing public resources in health. Just one more issue that we've looked at in WHO, looking at an area like infectious diseases, which receives a lot of international funding, because that's mainly what donors provide as financing for health in Africa. Part of the challenge is the way that this funding is provided, which is very vertically targeting individual diseases, and therefore loses the opportunities to finance some of these elements of a healthcare system like human resources, where if these sources of funding were combined in some way and the governments were able to have an integrated approach, they would be able to improve on the numbers, quality, competence, training of their healthcare workers, and I believe achieve more value for the investment, both by the governments and international partners.
Yeah, thank you so much, Dr. Moiti. That gives us a really great backdrop to sort of understand the state of universal health today, you know, and now that we are experiencing this global pandemic, I do want to get into sort of the impact that COVID has had and in what ways, you know, the pandemic has sort of set us back even further, and also it highlighted the need for services like, you know, community-based health and sort of making the financing available so that families can afford healthcare when they need it most. So I'd like to turn to Dr. Manlin and ask you a bit about, can you talk about sort of the interconnectedness between, you know, communities' health and the health of our economy, and how important that connection is? Because as we've seen during the pandemic, you can't really have a healthy society without healthy workers. So can you talk a little bit about that connection?
Thank you very much. Just to confirm, I'm not yet a doctor, even though I'm among very important doctors and professors. One day I'll complete it. The point that were raised by Professor Were and Dr. Moiti connect very well to some of the hurdles that we have on our way to reach universal health coverage. One of them is unemployment. And how do we get countries to actually grow the economy so that jobs can be created and not the other way around? And by having people that actually have some form of employment and the belief in the future and the ability to invest in their own health becomes part of what they do as individuals and as a community. The second one, why it is important, is because you want to be able to grow the tax base of government so that the domestic resources become more available. But in the absence of the conversation around how do we grow the tax base, and only speaking about how do we grow the sort of country's investment in health, it's a very difficult conversation because we're not looking at the same points. If we look at what the pandemic has done and the measures that were required to stop the spread, which were on physical distancing, in economies where the informal sector or the popular economy is large, it means that the foot traffic that allows for the sale to happen does not happen. And one of those consequences for individuals is that they may not get food on the table or may be able to send the children to school. And I'll take a final example on that element, which is something which we don't really think about or talk about, which are neglected tropical diseases. The science has allowed us today to be able to probably eliminate them in most countries, but we're still struggling to do so. The cost is very minimal in most countries, but we're still not able to do so. And that raises a question in terms of how do we solve for this thing that for which science has provided us an answer, but we're still struggling to do? And what are the implications for women in rural communities, for example, or young people that are supposed to go to school that still suffer from schistosomiasis, which are basically worms that does not allow children to actually go to school? Over.
Yeah, that's really important to remember that even in the backdrop of this pandemic, those existing diseases are still an issue, and of course, especially in lower income communities, these that already lacked access to healthcare before the pandemic, and so I'm sure that the pandemic has just added another layer of complication for those families that are already struggling with food insecurity and with other issues. President Frank, can you talk a little bit about, from your perspective, what do you think? Oh, sorry, a bit of an echo. What do you think are some of the ways that we can, use this opportunity to shine a light on some of these problems? And are there sort of common themes that we can look for to sort of improve the access to healthcare? And how do we sort of, building off what Carl was talking about, how do you ensure that people can still maintain, still get food on the table, as you put it, while following, best health practices and keeping their families safe?
My apologies for the interruption. I just want to say, if anyone has an extra Crowdcast tab open, that would be causing that feedback that we're hearing. So if anyone who's on the mic, just be sure to close any extra tabs that have Crowdcast on it, because that will be causing that feedback. Thank you.
Thank you.
Okay. Let me say that undoubtedly the pandemic has exposed the weaknesses of existing health systems, not just, by the way, in poor countries, but throughout the world, but clearly even more so in resource-constrained countries. The numbers on excess mortality are partly due to, we have officially 5 million people dead in the world from COVID, but we know that's a grossly underestimated number. And so we rely on the measure of excess mortality. A big part of that are deaths from COVID that were not recorded as such. But a big part of that are deaths indirectly caused by the pandemic because of the delay in access to otherwise needed care. I mean, we have seen a decline in vaccination, an increase in maternal mortality in many countries, including middle-income countries like my own country of Mexico, with a 30% increase in maternal mortality. Those are causes indirectly, those are deaths indirectly caused by the pandemic because of the delay once you put the enormous strain on the health system that the pandemic has entailed. And so the pandemic has exhibited that. At the same time, it's bare in the most dramatic way what Carlo was mentioning. We have been saying, those of us who work on global health, that health is not just a consequence of economic development, which it is. Economic development is one of the determinants of health, but it's also itself this of health, determinant of economic performance of countries. Professor Jeffrey Sachs, who's one of our hosts today from the UN Sustainable Development Solutions Network, he chaired a commission on macroeconomics and health in the year 2000 that clearly established the link from better health to economic improvement. Well, if we ever needed a demonstration of that relationship, we have had it now with the pandemic. Here you have a public health crisis, a pandemic, an infectious disease that spreads throughout the world, provoking the largest global economic recession in a century. So that opens a tremendous opportunity because, we don't need to preach to those of us on this panel. We're all convinced that health is very important. We need to persuade the economic decision makers, the ministers of finance, the heads of large corporations, the presidents and prime ministers of countries around the world, that protecting health is not just an end in itself, which it is, because human life is sacred, but it is also a means to improving economic performance. And I hope that one of the lessons of the pandemic is that with an infinitesimal amount of the economic losses to the world, the losses that the world economy has experienced through this pandemic, with a tiny, minute amount of that invested in health systems, we could not just prevent future pandemics, but overall increase the health of people, and through that, the economic performance through mechanisms, as Carl was saying. You increase the productivity of the workforce, you increase the efficiency of the investment in human capital, because children are able to learn better. Not just that, the main cause why children lose school years in Africa is because their teachers die of AIDS. And so improving health has that effect on building of human capital in itself by making people healthier, but also through other investments like education. So I hope that is the great lesson. And the other lesson is, of course, the need to rely on science, on investments in science. This is what's produced, among other life-saving interventions, the vaccines. But that investment is also needed to sustain other areas of global health. And so I think that alongside the tragedy that we have lost, we actually owe it to all the people who have lost their lives, their relatives, all the people who have lost their livelihoods, to actually learn those lessons. And I think for once we have the opportunity to make the case that investing in health is not just the right thing to do from an ethical point of view, it's the smart thing to do if your objective is to protect economic growth and development.
Yeah, no, I think that's absolutely right. And I think, as you say, if we ever needed an example of how interconnected they are, this pandemic has provided that. And perhaps that's not surprising to people who work in that field, but I think many countries sort of saw firsthand that there was this inherent tension between having a healthy society and a productive one. And in many cases, it was sort of presented as a false choice, that you had to sort of choose the economy, or you choose, to keep people healthy. And it was, of course, that is a false dichotomy, because you can't have one without the other.
Absolutely.
Dr. Ware,
one of the most negative effects of the pandemic was to pose those as conflicting objectives. Of course, you need to reactivate the economy, because people in lockdown without ability to put food on their table, their own health is going to fail. But also, if you reopen the economy in a premature and poorly planned way, as many countries did, then you not only hurt the health of people, you hurt the economy as well through future lockdowns. So I think that's a very good point. One of the lessons is that the two objectives are synergistic. There's not at all a trade-off, quite the opposite.
Right. Yes. And Dr. Ware, perhaps you can talk a little. Oh, did you have a question, or did you want to jump in? Go for it.
I think the whole idea of health affecting the economy, we have seen it even within communities, not only in national economy, but when we improve the health of a community, you can see that their economic well-being becomes better. So I think there are enough studies and enough that make that point. And I think the whole idea of community approach has now been established all over the world. I think in Latin America was one of the leading in Brazil, in Mexico, where they used the family health workers and changed things. And we have seen in Africa, the community approach has worked wonders in Ethiopia and in Rwanda. I mean, Ethiopia is one of our big countries. Rwanda is one of the smallest countries. And in both cases, the community approach has done wonders for the health. Ethiopia used to be 3 times maternal death compared to Kenya. And then they went 100% community approach. And now we are almost double their maternal mortality. So, and we do have community health in Kenya, but it's not 100%. And what I think we need is that we need a more interventionist approach through something like the Global Fund. You know, I used to be the chairman of the National AIDS Control Council in the early 2000s. And it was, we couldn't get money from, where does the government cut in order to focus on HIV? What funding can it stop doing? And we have the same problem now. What can the government stop to do in order to invest on community health approach? And these are difficult questions when you're in a difficult financial situation. So I think we need to think, the world needs to think very seriously about the possibility of a special fund for community health approach, such as a global HIV/AIDS fund, such as a malaria fund, and so on. We need a fund that the government doesn't have to choose from its limited resources to address the community health. And I think that by doing that, we shall show the government that we are supporting them not only in health, but also in economic improvement. Uh, I don't think we would have gone anywhere in Kenya in HIV/AIDS control if we hadn't had the Global Fund for HIV/AIDS. But with that approach, when I became chairman of the National AIDS Control Council, we had been moving very, very fast, almost 8% per year towards worse situation. By the time I became chairman, we were 16%. But then we took the community approach on HIV approach in HIV/AIDS, and we moved from 16% to 12% to 8%. By the time I left after 6 years, we were at 4%. And up to now, we have not moved back beyond 5% of HIV. So if we can do that in HIV, I think we can do it in everything. So I really hope that we can find a way to have a community health fund, a community approach fund that can be focused on that, externally managed, like we used to apply for the HIV/AIDS Global Fund, so that we keep, because I personally I have been talking about the importance of the government allocating to community health for the last 30 years in my country. But what do they cut from in order to do that? And unfortunately, for political reasons, the big hospitals are more attractive than community approach. So I think that we need to have an interventionist approach, community health fund that people can apply to, and that can now help us to move forward the community approach, so that we move towards the Ethiopia situation where we have 100% of the communities, all of them with a community health worker and working on community, like in Rwanda. So I think that is what we need.
Yeah, and I think it's fascinating that Ethiopia has this model, because I think, in many much wealthier countries, you see that there's a breakdown between the sort of formal healthcare system, which some people have access to, and then the sort of everyone else. And it's clear that even in wealthier countries, we lack that sort of basic connection between healthcare workers and the general public. And that's why when something like a pandemic happens, there seems to be so much distrust of the government and of health authorities, because they've never had much interaction before, and there's been a lot of neglect. So I like this idea of a public health fund. I'm curious, Carl, what do you think about that? And do you think this would help us be better prepared for new evolving threats like COVID?
I think there are some lessons from the different funds that we had, and Dr. Moeti mentioned the vertical approach. We can't have vertical approach anymore. We need to find a way to ensure that we look at the human being and think of One Health. Therefore, we can't just be taking care of that infection or reproductive health. But because when we're thinking about the economy, we want the full person to be able to be active. And that is really the key part that we also need to bring from the private sector, thinking about how do we look at the individual or the community. Yes, we need that extra funding. But if you think about the model that we have had in terms of this large replenishment, the world has moved, and I am not sure that we will be able to raise this kind of funding again in the near future. Not because people are not willing to do so, but it's a question around if we have 20 cents to the dollar, where do we put it best to make sure that people can move forward? And the community element is extremely important, but we can't just have community health workers, for example, that are not paid. Is it a full-time employment but who's going to take the bill? Or do we think about what are the opportunities to grow this community? Let's say if it's a rural agricultural based community, what do we ensure that we can transform what they produce so that the value addition process increases their revenue? So again, the funding of health has to start at the local level. And I mean, Professor Were had a very important quote where she speaks about things happening in the community that happen in the nation. So when we're speaking about community health, we need to think about community growth, opportunities for this community to leverage on what they already produce to be able to move forward. I am not against the principle of the funds, but we have to remember what these vertical funds have done, and did they help us to alleviate the pressure, for example, of the burden of COVID-19 today, or even a couple of years ago with Ebola in West Africa or Ebola in DRC.
Yeah, so I think that's a good point, that there should be this sort of grassroots level. You can't just have this top-down funding without that kind of accountability. I'd like to just ask a question.
If I could just,
Go ahead.
On that. Yeah, I mean, I just wanted to add, sympathizing very much with Miriam's point of view, 30 years, goodness, of plugging away at this idea, which we all accept is very important, but somehow it does not translate. So in a way, all the money that's been coming into countries, so from the Global Fund, from rollback malaria, from other global funding instruments, how come is it that countries haven't been able to convince, or perhaps haven't tried, to decide how this money is spent so that it goes towards contributing to this very efficient, if you like, investment in community health workers who have such an impact on health, in addition to, as opposed to some of the investment in big central hospitals, which the majority of the population can't even reach. So I think it's also a matter of the policymakers, the negotiation, that very often when these instruments are being discussed, governments are told to get into the driver's seat. So when they do, what is it that they are going to ask for in the driver's seat, and how can we help them to understand with data? What do you get if you invest your money in certain ways, and the opportunity is lost if you invest it in certain different ways? So, I mean, Miriam, I hear you've been at this for 30 years. So what do we need to do in terms of the advocacy, showing the evidence, helping them to understand this is a smarter way of investing the same amount of money in terms of the value you get out of it, and really helping to make decisions that are based on evidence, experience, in helping the resources that you get, both national funding and very much influencing international funding. And also asking the international funders to also look at the same evidence. Of course, at the same time, we know there's a lot of work that needs to be done to build the accountability systems so that people feel happy without having to track every cent that they put into the country right to the village level, which is how many of these funding mechanisms are structured, which then drives the inefficiency in terms of how the country can cross-finance some of the basic services in ways that also apply to how you deal with populations. You don't deal with a malaria part of a person today and an HIV part of a person. We're trying in WHO to encourage dealing with population subgroups. If you have the good opportunity to have a child come to a clinic, my goodness, you need to make the best of it for everything you can possibly do for that child, for prevention, for access to treatment, etc. So I think this is some of the work that we need to do. I also just wanted to add briefly, without taking up too much time, to what Professor Frank has said around investing in health, to say that and in looking at the experience of the pandemic, we also need to look very closely at the issue of equity in terms of that investment. So the glaring inequities that have been exposed both in wealthy and in poorer countries, first by who was most vulnerable in these countries, who was worst affected by COVID-19, which goes back to inequitable systems in countries right down to income, work, housing, and access to healthcare, which made some people more vulnerable, and how important it is as well in our context in Africa going forward, that we know that if you look at the most difficult circumstances, conflict zones, remote rural areas, difficult to reach areas, this is where the mortality rates, access to services are worst. And then at the global level, we've seen the drama of the inequity in access to the tools to deal with the pandemic, including access to vaccines today, which rolls back into a continuing risk for everybody. So I think we need to think about it in that way, even from wealthy countries, that, we need to think equity in order to address the risk in those vulnerable contexts and to address our own risk, because we have a shared risk. I think that's something that's also very important to emphasize.
Yeah, absolutely. President Frank, do you have any thoughts on this? How do we address these inequities in, countries across the income spectrum, and how to, because as others have pointed out, it's not just a problem in poorer countries. It's something we've seen here in the US, and I think in many other countries that we may have thought would have been, better prepared for a situation like this. So how do we address those inequities within countries?
Yes, when we talk of universal health, we need to be very conscious about three fundamental goals. One is equity. It's not just about increasing average levels of health, but also closing gaps. The other is quality. It's not about assuring access. You need to assure that the quality of those services is good, which means that it actually solves the problem for which that service was meant to address. And the third, very important dimension is what Dr. Moeti said at the beginning. It's financial protection. There's, the conservative estimate is 100 million people who every year experience catastrophic or impoverishing health expenditures. And therefore, improving health, which should be one of the most potent tools to improve the economy, that effort becomes in itself a cause of impoverishment. It's the most unacceptable paradox when people not just lose their health, but also become impoverished because of their efforts to restore their health. And so those three have to be pursued simultaneously, and it has to be a deliberate attempt. There is a concept that I like very much by Davidson Watkin, progressive universalism. Progressive not in the political sense as it is used in American politics. Progressive meaning that you deliberately start with the poorest groups in the population. When I served as Minister of Health of Mexico for 6 years, we introduced a program of insurance, publicly funded, that started with the poorest members of the population. And after a few years, more than 50 million people who were previously uninsured had been protected. Catastrophic expenditures went below. It drove an improvement in the investment, the public investment in health. So there are experiences that this can be done. This idea that you start with the poorest groups, you emphasize and prioritize diseases that disproportionately affect the poor, which are, by the way, not just infectious. Chronic non-communicable diseases also disproportionately affect the poor. And you have equity as a driver and an explicit goal, and you judge the performance of your health system not just by average improvements in health, but by also the extent to which you reduce those gaps. And that, I agree completely with Dr. Moeti, has to be one of the big lessons of this pandemic.
Yeah. Great. Well, thank you so much for that answer. And also, I just, at this point, I realize we have about 10 minutes left. So I wanted to make sure we had a little bit of time for audience questions. And just a reminder, if you have questions, just put them in the Q&A box at the bottom. We already have a few in here. So I wanted to start with this question about what is the role of private healthcare providers in a world where universal healthcare is a reality? So if anyone wants to jump in and tackle that one.
I mean, what I could say is what's critical is to have public funding. The most mature market economies in the world, the majority of health financing is public. It comes from taxation or from mandated social insurance contributions. If you have that, and if you had good stewardship from the public sector, good public stewardship to assure standards of quality, whether a provider is private or public is not the key issue. We often confuse the debate there. What determines whether a system is public is the fact that funding has to be public, and there is ample evidence that it's publicly funded because health doesn't allow itself to be healthcare, doesn't follow the rules of market allocation. You will exclude a lot of people, including the sickest, if you follow that. But private providers have a very important role to play, including community providers, which very often are not public or civil servants, provided there's public funded and provided there's a framework of stewardship and regulation that assures quality levels, quality standards, and enforces them.
Yeah, I think that's true, that certainly you cannot separate the two completely, because without that public investment, there's not going to be any sort of regulation of the private healthcare market. And, in countries like in the US, where a large percentage of the healthcare is private, you rely on these public investments in especially things like Medicare and older, care for older populations. So you can't really have one without the other. And I wanted to
I was just going to
sure.
say, I mean, just following on what Professor said, we have to guard against then, I agree with him very much that the governance needs to be very robust so that you guard against high cost private care absorbing public funds while serving a small proportion of the population, and the more public system that is struggling with the burden. And that's what we see in a couple of our countries in the region, particularly in South Africa, where the government is trying very much to reform the system over a number of years. I think that's what needs to be guarded against, and the governance needs to be robust, as he said.
Mm-hmm. Professor Ware? Sorry, I think you're muted, Professor Ware.
You're good now.
Is it?
We can hear you now.
Am I muted?
No.
Can you hear me now?
Yes.
Yes, we can.
You can? I was just saying the importance of paid community health workers is really critical, because in every situation where things are working better, usually it is because either people are economically okay or they are paid community health workers. And Ethiopia is a very good example. And I think that that's one of the areas where in many of our governments, they have a problem finding the money to pay the community health worker. Therefore, they are not in the workforce, in the health workforce. But if you have a fund like the Global Fund for Community Health, and I don't think we should call it public health. Public health is too broad. It can go into everything. But if you say community health workers, so that we can focus on how to pay community health workers and how to make a comprehensive program for community health, then we deal with everything. When we do this, we have dealt with infectious diseases, we have dealt with non-communicable diseases, we have dealt with hygiene, with nutrition, so effective community health workers are really good from every perspective. And simply to say an urgent thing, and you know, health is the background to all the other 16 sustainable development goals. Without a healthy population, you can't do any of these others. So if we are healthy, we can do the others. And I think that at the beginning of health is every community being healthy. And we can do that with community health workers in community health systems. So I don't know what else one can say.
Does anyone else have a comment, or shall I? Just wanted to have time for maybe one more question here. So here's a question. To what extent is universal health care a question of financial resources as opposed to political will and investment of both political and human capital? Workforce development is perhaps a neglected issue. Does the panel agree?
Well, I would echo here the legendary Professor Ramalinga Swami from India, who said, you need more money for health, but you need to assure more health for the money. So it is an issue of financial resources in a lot of countries, certainly in the poorest countries. There is an underinvestment. There's been a massive epidemiologic transition in the world, including the poor countries, the poorest countries, not just the higher or middle income countries. And today, every country in the world is facing a triple burden of disease, an unfinished agenda of infectious diseases, a rising tide of non-communicable diseases without having completely dealt with the unfinished agenda. That way it's unfinished. And then on top of that, health challenges directly stemming from globalization, like the health consequences of climate change and, of course, pandemics. So the stress on health systems is unprecedented, and it requires adequate allocation of resources. And unfortunately, many countries do not prioritize that. That's why I say I hope now with the pandemic we realize with a minute amount of what the economies have lost, we could fund robust health systems in every country of the world. But health systems then it's a social compact. Then they need to assure optimal health outcomes for the resources investment. And that's why it's more money for health and more health for the money.
I like that.
I mean, I guess I found the framing of the question interesting in the politics. I mean, of course, it needs policy decisions in a certain direction. And unfortunately, we've seen with the pandemic, the politics really getting up front and being very dominant in terms of ideological positioning, etc. But I mean, I do think it requires conscious, deliberate policy decisions in terms of how you focus on certain things or how you transition from other approaches in order to get to these aims and objectives without the kind of politicization we've unfortunately seen sometimes with regard to the pandemic, which to somebody who's not a politician like me looks a bit extreme and getting into the way. But I say so with all humility, let me add.
I think what both Professor Frank and Dr. Moeti said is a question of access. And even if you build those systems, how do we ensure that people have access to them? And this applies to health, this applies to economics, and building that element around equity and closing the gaps for more people to be able to access probably where they are and as close as possible to where they find themselves is an important one. We've seen some of the scenes around people traveling to go and get the vaccine, and what are the implications for that in those communities?
Yes, I think equity is certainly a big part of it, and you can't, separate that from how the money is spent and how who gets access to the healthcare that we're investing in. So I think that sort of brings us full circle, and I just wanted to sort of thank all of you so much for taking part in this panel, and it's been a really fascinating conversation. Thank you to everyone who's watching. We've had lots of interesting questions, and I just wanted to, wish all of you good health and throughout the rest of this pandemic. And hopefully we can, learn some lessons that extend beyond this immediate crisis to help us be better prepared and healthier in terms of our economies and our societies. So hopefully we've all learned a little bit from this discussion, but of course it's only sort of the start of a much broader conversation. So thank you, everyone, and I will turn it back over to, I guess, whoever's on the back end here.
Thank you. Bye.
Thank you.
Thank you, everybody.
Bye-bye.
I haven't seen thankful, yes.
Okay.
Dr. Moet, what are you doing? You are looking younger, Emily. I see you look younger.
No, it's because I'm reduced to my basic self by the COVID-19 pandemic.
Pardon?
I said I'm reduced to my basic self by the COVID-19 pandemic. There's no time to do anything except be on